Everybody can see my screen. Is it full screen?
No,
sorry,
it's not.
Okay, hi everybody. Welcome to this session on fighting water-related epidemics with long-term approach and research, where we will discuss the approach of research and emergency and multisectoral responses in fighting epidemics, with a special focus on cholera in the first part, then final part on the COVID response. And for this session, I'm glad to have 4 speakers with us. So sorry for the first one on the slide is not available for the session. We were glad he could be present, but unfortunately he is absent. So we will start right after my introduction with Bram Reams, who is Senior WASH Advisor at Action contre la faim. He will be presented an approach called CATI with Baptiste Lecuyot, Senior WASH Advisor at Solidarité Internationale. Their presentation will be then followed by a presentation done by Bénédicte Vallès, who is a partnership manager at the Veolia Foundation. And she will show us a case in DR Congo where they are running a multi-sectoral approach through partnerships in the cholera fighting. And in the end, we'll have with us Aline Tageling, who is operation manager for Uduma in Mali. And she will present us their solutions to provide water to suburban and rural areas and what they did during the COVID-19 epidemics. I'd like to start with a few words on cholera for those who are not really familiar with this disease, and to say that it's an acute diarrheal disease and the infection is caused by a bacteria called the Vibrio cholerae. The transmission route is fecal-oral, so basically it can be transmitted through contact, water, food. And this disease is having like 1.3 to 4 million cases a year worldwide. This disease is also killing people from 21,143 yearly. And worldwide, at least 47 countries are concerned, with more than 50% of the cases are reported in Africa only. So as I said, it's a water-related disease, so lack of access to safe water and sanitation is triggering these kinds of disease. And waterborne diseases are causing 3.3 global deaths per year, so 2 million people dying. And 53% of them are located in sub-Saharan Africa. And 13% of children under 5 are dying from waterborne diseases. This might be a bit alarming, but this is the reality of waterborne diseases. So to come back a bit to cholera, I'd like to give the floor to Bram and Baptiste that will present us an application of research in the cholera fighting that they have been implemented through their program in different countries. Bram, Baptiste, I'll let you the floor and show you the PowerPoint.
Okay, thank you, Florent. Can you put it in full screen? It's not really, it's like,
okay,
well, it's a bit better, but.
Yeah, sure. 1 minute. How is it?
Yeah, I mean, it's better. Okay, put the first slide, please. So, hi everyone. I'm Baptiste Lecuillot. I'm the Senior WASH Advisor for Solidarité Internationale. And today, with my colleague that is going to present himself right after, we are going to do a presentation around ways of potential improvements of cholera outbreak response in a specific settings in relation with an operational research that we have been conducted recently. Bram, the floor is yours.
Thanks, Baptiste, and thanks all for joining this at this rather late hour and sometimes heavy temperatures. So can you go to the next slide, please? As Florent just introduced, there's still a lot of cholera around, unfortunately, because it's a disease that's so easily treatable. These are a couple of the biggest outbreaks we've seen in the last couple of years. So the biggest one in recent human history was the one in Yemen, affecting 2.5 million cases. Before that, the biggest ever recorded in history was the one in Haiti, which ended in 2019, so over 800,000 cases. A lot of cases also in DRC. A very recent one that we will focus on during this presentation was the one in Nigeria, which started end of last year and went up to the beginning of this year. And as you can see on the map, a couple of other hotspots like Somalia and South Sudan. And this is just a couple of examples. Next slide, please. It's a small picture, but let me draw your attention to it. As I was mentioning, Haiti, so the next two slides will be about Haiti as a sort of entry point, because it's a good example of where the approach that we will talk about, the response, came to form. The picture here is actually an intervention we did where we had the last cholera cases in the decade-long Haiti outbreak. It was, what you see is a water treatment unit, chlorinizes water, treats it, and it was pretty easily, it was a pretty easy intervention in the way that the spreading of the disease, the main source was a local river people were using for drinking water. So it spread quickly in the community. There was no other water source people were using. We could fairly easily identify the river as the main infection, the main source of infection. And this is one of the things we did on top of a blanket approach, which in a humanitarian intervention means covering as many people as you can. So what did we do? Community sensitization, going door to door, gathering people around to pass on the main messages on how to prevent cholera, distribute a basic cholera kit, and disinfect as many households as we could. Now, this was a small rural area. It's a blanket approach, and this was appropriate in the final days of the Haiti outbreak. But in some cases, it's not always the water source. There's the source of infection, right? So we have to know, is the water point actually contaminated? Sometimes it isn't. Still, many humanitarian responses do this as the first intervention. They start chlorinating the water point. Is everyone at the same risk of infection? Can we cover entire areas in a very short time? These are big questions that lead us to believe that this blanket approach is not always the best one. On the contrary, I'll leave it to Baptiste to go on.
Next slide, please. Yes, thank you. So what was done is a more effective response was developed. So first of all, sorry for the fact that the elements are in French in the diapositive, but I guess we can understand them because it's graphic element. So this is where we can speak about the sword and shield strategy that you have probably heard about. So what is it about? It's about combining both preventive and a curative WASH responses with continuous epidemiological surveillance and analysis that allows to be more efficient and more effective in fighting outbreaks. The shield part, as you may see, is much about prevention, informing the response, building capacity of the stakeholders that are involved in fighting cholera outbreaks, and of course around sensitization and long-term WASH development activities. By, of course, having the idea to prioritize what we call hotspots through the epidemiological surveillance. And this happens in inter-epidemic stage. The objective of a shield approach is basically to reduce the risks of exposure. In another hand, you have the sword strategy, which is built around preparedness and contingency to allow a rapid and reactive response that is, if possible, geo-targeted, and we will come back to that, and that covers a range of activities depending on the transmission context, as it was mentioned by Bram just before, targeting household, public places, and health infrastructures with the objective to break and to reduce the transmission during the outbreak. Can you go to the next slide? Okay, so now that we have been through a bit of an overview of what are the main elements of a cholera response, let's go to the specific operational research that we have conducted in Nigeria. So first, let me give you a bit of regional context overview in terms of the cholera situation. The Nigeria region with the countries around, it's an endemic area for cholera with great numbers of people that are at risks. There are lots of cross-border transmission that is not always easy to monitor because most of the time, if there is a monitoring system in place, it's at national level. Nigeria plays a central epidemiological role within this region. There is a lot of movement, of course, within the Lake Chad Basin, the Niger River. So all of these are potential paths of transmission of the disease. And in top of that, these areas is fed by humanitarian crisis with intense conflicts that, of course, cause issues of accessibilities, but also a lot of population movements in direct relation with the conflict and the natural disaster that can occur. Next slide, please. The one before, yeah. Yeah, this one, thank you. So now let's have a little bit a look of the epidemiological situation in relation with the last outbreak that occurred in Nigeria. It was quite a massive outbreak with more than 110,000 suspected cases over a short period of time. As you can see, it has spread all over the countries, but with some states that have been heavily affected. And that was particularly the case of what we call the Bay states, that are the states located in the northeast Nigeria, where most of the humanitarian actors are working. you can see the CFR of 3.2% over the whole course of the epidemic. And you can see both the epidemiological curve and the death curve associated with that. Now let's go to the next slide, and I'm handing over to Bram again.
Thanks. So what we tried to do with both ACF and Solidarité is to respond to the outbreak, obviously, with what we call case area targeted interventions. To the graph on the left, it's very hard to see. So very quickly, the risk of getting cholera increases 36 times whenever a household lives in a 50-meter radius to the suspected case. It increases, I can't read it myself, but I think the risk is up to, what is it, eight times, and then 5 times for a 100-meter radius and a 150-meter radius. In short, the closer you live to a suspected cholera case, the higher at risk you are of getting cholera, right? So this is the rationale for doing case area targeted interventions. You not just target the case itself, the case which is presenting itself to the cholera treatment center and gets registered on a line list, but you also target the immediate surroundings and neighbors of the case to stop the spread. This is one type of response. This is not the only one. You could also say we'll only target cases. You could also say we'll focus on clusters of cases and perhaps drop others. So this is just the one, but this is the one we've opted for Nigeria. So what's the package? What do we do, especially with WASH? Is we do hygiene education, do disinfection of the household with chlorine spraying. We distribute items. There's point of use water treatment with chlorine as well. Case investigation, case referral. Yeah, let's go to the next slide. This is still me, I suppose. What we did is, together with a response, we wanted to evaluate whether this was more effective than a standard response, which would be let's say a blanket response, namely covering each and every household in an entire area, right? So what we did is we developed a research study together with Johns Hopkins University. The objective was twofold. How effective is the CATI approach in reducing cholera cases? And can we see a relationship between the timeliness of the response, how quickly they respond, and incidence of new cases, okay? The comparison groups were established according to the timeliness of intervention. This means those cases that have been responded to within 48 hours were compared with the cases that we responded to beyond 48 hours, so in a later time. Obviously, the objective of a CATI response is that it occurs within 48 hours. The quicker you get to a case and to a potential neighboring case at risk, the quicker you're able to reduce the spread. That's the logic. Next one is, I guess, still for me. So this is the methodology. We did the study concurrently, so at the same time of the response, basically. So this is obviously a challenge, and we'll get to that further down the line. What happened with during the response? So a case, whenever someone gets sick and gets symptoms of cholera, she will go to the cholera treatment center. She will be registered on the line list, which you can find under the research piece. An alert will be sent to the rapid response team, who will go out to the field to where the case lives, to the household, do the package of intervention, including household disinfection and so on. Whereas for the research, there was an interview that was done. And then in the first phase, cases and neighbors were observed. And a second survey, 1 week or 2 weeks after the intervention, was done to see if there were any additional cases that came up. I guess I'll leave it to you, Baptiste.
Yes. Next slide, please. So here it's a brief description of the activities that have been implemented during the interventions. The intervention being coupled with the research itself, as mentioned by Bram. So what SI and ACF has done is basically to provide the core activities that are related to the CATI CATI intervention, which is for the case household, cholera kit distribution, hygiene promotion, disinfection by spraying. The only slight differences was that SI used 2 concentration for that. And free chlorine residual testing at the household to ensure that the water is drinkable. And then targeting the neighboring household around the cases, distribution of soap and aqua tabs, hygiene promotion, and also disinfection. From time to time, FRC testing was done at the neighboring household, but that was not systematic. The radius targeted was 150 meters. That's quite important, and that brought a lot of challenges that we will come back to right after. So what we can see that we both had the same type of activities, the same number of teams, 10 rapid response teams for SI and 10 for ACF. Covering different states and working from 4 to 5 CTC for SI and around 3 CTC for ACF. The CTC, the cholera treatment centers, were the places where the line lists were analyzed and where the cases were identified to trigger the intervention. Next slide, please. So here it's 3 different epidemiological curves that correspond to the different states in which we responded. So the 3 base states, Borno, Adamawa, and Yobe, that are all in northeast Nigeria, as you can see on the map on the top right corner. What is interesting to mention is that for both states, at least one of our 2 organizations started to respond at the first peak of the epidemiological curve, or around the first peak of the epidemiological curve. This is a bit late. Obviously, the idea of targeted intervention and also the idea of having a robust epidemiological surveillance system is to be able to trigger the intervention as early as possible to limit the transmission of cases and to break the dynamic of the outbreak. Next slide, please. Now we are going to look at some preliminary results. So it's important to mention that it's only preliminary results. The data are still under review by Johns Hopkins University, that are our partners, our academic partners on the study side. They have a lot of data to clean and to analyze. Therefore, what you see can be subjected to changes in the future. We are going to look basically at key indicators that can characterize the efficiency of the intervention. The first one is the coverage, which is shown on this table. What you can see is the number of cases also that have been responded to by state and by organization, and the number of neighboring households that also received the intervention. It was quite an important response because more than 2,000 cases was covered, and almost 50,000 neighboring households were also covered. Maybe what is important to mention is that the general coverage percentage, which is the number of intervention over the number of cases identified within the line list, is between 45 to 65%, more or less, with an average of 55%, which is also not so much. We aimed at reaching more around 80% of coverage. Of course, it brings a series of questions that we'll try to discuss a bit during the conclusion on how we can increase this percentage, and there are several ways to do that. Maybe another important point is to mention that the average, the median numbers of neighboring household by case household varies a lot, from 8 to 35, which also is explained by different parameters. The size, I mean, the radius size that should be the same, the density of the population, the urban and rural context, etc. That's it for this slide. So, Bram, to you.
Sure. Yeah, I won't dwell on this for very long because, as Baptiste said, this is preliminary results and this is still under analysis. This is two graphs around the timeliness of the response. As I said, it's really crucial to respond as quickly as possible and ideally within 48 hours. So this is obviously one of the main indicators that we'll have to look at. And when we look at the time to response, you can see that it differs by state as well. So for instance, the left graph, the ACF intervention, you'll see the orange is in one state in Yobe and the blue is in another one, is in Borno state. And you can see quite a big difference in terms of time to intervention, with the lowest rows being the more effective ones with an intervention of within 1 day or within 2 days, within 48 hours. So these are the good rows you want to see. You want to see these being ideally 100%. Same for Solidarité, with an additional third state. Obviously, they also intervened in Adamawa. So it's really hard to see. So if in terms of general average response within 48 hours, we reached just below 50% in Borno state, that's for ACF, and 75% in Yobe. For Solidarity, it's 36% in Borno, 94% in Yobe, and 39% in Adamawa. Preliminary figures. Next slide, please. These are the type of activities we implemented at case and neighboring households. Obviously, you also want to know, did we do everything in the case households as well as in the neighboring households as we intended? It's a bit of the same. I think the top rows are the maximum package that we would like to implement. At the left in the case household, at the right side in the neighboring household. So we're not necessarily achieving very good figures overall, although the minimum, in terms of minimum, for instance, the lower lines, the lower rows, in terms of the type of supplies, the kit we distributed, this is fairly good. It's getting towards, let's say 100% in the case household. It's a bit lower at the neighboring household. Yeah, not going to dwell on this too long. Perhaps the next slide. And this is you back again, Baptiste.
Yes. Okay. So now let's go a bit to the conclusion and try to draw some perspective at this stage. Of course, as mentioned several times, it's still work in progress. So we will be able to draw better results and recommendation in the future. Obviously, the idea is to try to understand what are the constraints, what are the operational challenges and considerations, and how can we take into consideration these operational constraints and improve the performance indicators of the response. One initial point is that having research done in the same time as the intervention highlighted how important is it to be able to do a geo-targeted monitoring online and I mean a continuous geo-targeted monitoring to better adjust the responses. That is for a start, and this is something that is quite powerful, but that needs to be properly used and properly prepared. One important aspect is the difficulty to cover this radius of 150 meters, particularly in dense context. And there we are speaking about Northeast Nigeria. Some of the areas we intervene in Borno, it's urban areas, which means that within a 150 radius, you can have quite an heavy numbers of households to cover. But this is something that needs to be, let's say, adapted to the context you are operating. Obviously, if you are in a very rural context with a very sparsely habitat, then you can maybe apply a different setting. So what is important is to define a radius that is relevant for the context you are intervening in. And of course, the question of the radius bring the question of the capacities of your team in terms of coverage, and also the capacities of your logistic in terms of bringing in the supplies that you need to implement the response. So then the question that will come with that is, with limited resource, what should we focus on? Should we try to reach 100% of the case household that have been identified within the line list, and then deprioritize the coverage of the neighboring household, because we want to focus first on breaking the transmission at the case household? Or maybe should we focus on targeting a cluster of cases instead of individual case? But for that, we need to have a system that allows to identify a cluster of cases, so a strong monitoring system. As mentioned, there are different variables. How do you measure properly this 150 radius when you are on the field, that you have some different streets in different direction? Do you do it only with your steps? Do you do it only by your intuition? So this is something that needs to be properly addressed. And of course, with these different parameters come the question of improving the coordination between the different response team, so that we are sure that they are at the right location and that they can target as much as possible as household within their geographical perimeter. Of course, there is the use of technology to standardize measurements, but also to ensure that geo-targeting is properly done. There is a question of security and access. We are speaking about very conflict context, where it can be quite difficult to reach some areas, and that requires some preparedness. There is the question of the communication, the internal communication between, for example, the CTC and the different response team, but also the external communication with the community focal point to ensure community mobilization and to mitigate also the risks in relation with community refusal. So should we increase HR and logistics setup, basically teams and supply, or should we decrease the radius? Is there a specific and ideal setup size that will allows us to be as much efficient as possible within a specific outbreak dynamic? All these are questions that we are trying to ask ourselves to improve the response. I will hand over to Bram.
Aside from operational considerations, there were also some research coordinations, because Johns Hopkins did the research remotely, as mentioned. They weren't in Nigeria because of security constraints. And they followed everything basically using a tool you might be familiar with. It's called mWater. So everything was inserted into mWater, and they could follow the data on a daily basis. But it is not ideal. And so having an in-country research officer is definitely something that would have improved the quality of the research. Let me draw your attention to the picture on the left. So this is a CATI ring. So the radius, radius is obviously a circle. It's from a dense, more urban area. And if you look at it, you'll see that it's not a good radius. It's a street. So people intervened in the neighboring households following the same street. They didn't cover the radius as they should have. So this is just an example of how it wasn't very well implemented. Another example is the radius to the left bottom. So there's always two. There was the first the intervention, and there was the 1 week or 2 week follow-up, and you can see there's no perfect overlap. So this is also due to slight errors. Other issues are obviously, Baptiste mentioned it, it's a humanitarian setting, it's a conflict setting, it's very difficult to intervene, let alone doing research on top of it. And it is an observational study in nature. It just follows the response. What we couldn't do, for instance, is design a research study that would compare a standard blanket approach response covering all the households in an entire area with a CATI response because of obvious ethical reasons. Other impacting parameters, significant delays, poor reporting of cases. That includes cases on the line list. It includes cases that are targeted by the WASH teams in the field that do not necessarily correspond. So it's data management, capacity for sample transport and confirmation is an issue in every outbreak. And definitely, and not in the least, access to medical treatment. Whenever somebody presents symptoms of cholera but doesn't go to a cholera treatment center, this person or this case will obviously be missed. A final slide for people who might be interested. We have developed cholera standard operational procedures, standard operating procedures, SOPs. It's a toolkit that ACF developed. It's 21 different tools encompassing everything from coordination of the response to doing cholera case management, so treating cases, to how to prepare for a cholera outbreak, to doing community outreach, to how to engage the support functions in your organization, and so on and so forth. It is based on the CATI approach because we believe the evidence is there that this is the most effective one. and it's not yet available publicly online, but it will be very soon. This is it for me. Thank you for your attention.
Thank you, everyone. Florent.
Yes, thank you. Thanks for this comprehensive description of the CATI approach and your work in the field, specifically in Nigeria. And thanks for sharing all those challenges that you faced during the implementation. Now we'll go through an example of partnership, multi-sectoral one, developed by the Veolia Foundation in DR Congo in South Kivu. I will let Benedict take the lead on that, and I will manage the presentation. 1 second. And for those who have questions for our speakers, don't hesitate to put some question in the chat box. We will discuss that after the presentation, which will finish around a bit less than 20 minutes now. Thank you. 1 minute, Benedict, for the sharing.
Yes, thank you, Florent. I'm just going to present myself. I'm Benedict. I'm a partnerships manager at the Veolia Foundation. Thank you also, Bram and Baptiste, for the insightful presentation. It's very interesting to listen to you. And I'm going to present an example of how countries can elaborate long-term strategies to eliminate cholera by choosing to follow a multi-sector approach, focusing on access to water. And just to correct Florent, that we would love to be the instigators of this strategy, but we did not do it alone, as it relies on a multi-sector approach. You may, when you can, you may shift to the next slide, please. Thank you.
Is it okay? Full screen, everything?
It's absolutely perfect. Thank you very much. So this multi-sector approach, which we like to call the magic square, includes governments and more generally public authorities to design and lead the implementation of national strategies, the civil society to make sure that the strategy is tailored to field needs, and this includes NGOs, of course, but also social groups such as women or religious leaders, etc. The private and the public sectors to implement the strategy, such as enterprises, international organizations, NGOs, local and international. Local and international experts that work hand in hand, and they can be of any kind. They can be consultancies, they can be technical experts, and of course, very important in this case, researchers, to ensure that the strategy relies on solid scientific evidence. And finally, donors, because for projects to happen, funding is needed. And next slide, please. Thank you. In DRC, one of the countries that report most cholera cases in the world, and if I repeat Bram's data, I think he mentioned 150,000 cases reported between 2013 and 2017. Public authorities have pioneered a shift in the fight against cholera from a curative stop-and-go approach to a new long-term objective of cholera elimination. And what is specific about this strategy is that it includes not only the medical sector, but it considers that all relevant sectors should be mobilized to address this public health problem. And this did not happen overnight. I'm first going to tell you more about the genesis of what became DR Congo's multi-sectoral strategic plan for the elimination of cholera, so-called PMSEC in French. And after this, I will present to you a concrete example of its implementation on the field. Between 2000 and, no, that was the right slide, thank you. Between 2002 and 2008, field research that was partly supported by the Veolia Foundation was carried out to understand how cholera and other waterborne diseases spread in the country. And the aim of this research was to define a prevention and response approach to cholera epidemics in DR Congo. Public authorities, in particular the Ministry of Health and the Directorate for the Fight Against Diseases, were mobilized, as well as Congolese and French scientific research organizations, including the National Institute for Biomedical Research, the University of Kinshasa, University of Franche-Comté Besançon, University Louis Pasteur of Strasbourg, and the Institute of Medicine and Applied Epidemiology. The Veolia Foundation contributed to funding the studies. Researchers identified 8 source areas of cholera in Eastern Congo, all located around lakeside regions. And this constituted the basis for the now widely used hotspots approach in the fight against cholera in DR Congo, such as the CATI approach that was mentioned by Bram and Baptiste. Researchers also noticed a seasonal pattern, and they found out the number of cases increased during the rainy season. And finally, most importantly, they demonstrated that access to safe drinking water was needed to be addressed as a priority to control the disease in the long run. Next slide, please. On the basis of these scientific findings, the government officially launched a strategic multisectoral plan to eradicate cholera and combat diarrheal diseases, PMSEC-MD. And the strategy, which relied on Magic Square, included the so-called shield sword approach mentioned earlier by Baptiste, and that included epidemiological surveillance, prevention measures in targeted areas, including wash measures, the treatment of infected patients in CTCs, reinforced coordination between stakeholders, and of course, promotion of research. The Ministry of Health and Ministry of Water Resources participated in this plan. The research organizations that I mentioned earlier, and on top of this, operational actors were included, such as the Régie des Eaux, the Congolese public company for the management of water infrastructures, as it conducts the construction and rehabilitation work and managing the infrastructures. The Veolia Foundation was also included, in particularly its corporate experts, to bring technical expertise to support the Régie des Eaux, as well as international and Congolese NGOs for social measures and medical support. Donors included the Veolia Foundation, the European Union, and the French government via its French developing agencies, and UNICEF as the WASH cluster coordinator. Next slide, please. Thank you. These first years of experience show that more sectors were relevant to be included in the strategy. So 5 other ministries were included. The Ministry of Planning, of Health, of course, Ministry of Environment, Transport, and Rural Development. And the new paradigm in this plan was to increase attention to prevention measures by ensuring a continuous access to potable water, sanitation facilities, and health education programs. The plan defined different actions to be undertaken, all of equal importance. There were urgent actions, prevention, preparation, and response, so shield and sword. Transition actions with the involvement of civil society and home water chlorination. And finally, transition actions that included building and rehabilitating resilient water infrastructures. And the multi-sector approach was renewed in 2018, taking consideration of added opportunities to fight cholera, such as vaccination and the Global Task Force against on Cholera Control, GTFCC 2030 roadmap. A new PMSEC 2023 to 2027 is being designed and is to be implemented in the next 4 years. Next slide, please. Thank you. And to illustrate concrete actions resulting from this PMSEC approach, and in particular the transition phase that I mentioned earlier, I'm going to present a project funded by the French Development Agency, the European Union, and the Veolia Foundation in the city of Uvira, which is located in South Kivu on the lake, on the shores of Lake Tanganyika. And the city of Uvira was identified as a cholera hotspot. And now the situation is called an endemo epidemic, meaning that the cholera is constantly present in this region, even outside outbreaks. And if you may, Florent, click on the video on the next slide. Oh, yeah, pictures irrelevant since the video is going to be there. That would be better to present the project. Thank you. And hopefully it will work.
Can you see the screen?
I think that since you're presenting, you need to, I don't need the next slide. So if you just show YouTube,
I will put the video, yeah.
Thank you. But it doesn't seem to work with the sound.
Sorry?
We can't hear the sound of the video, but if it doesn't work, it doesn't matter because we have the subtitles anyway. It would just be minutes of silence.
Got it?
With the support of the European Union and Oxfam, have undertaken a plan to optimise the water supply network. The objective of this €15 million project? Fight cholera, an acute diarrheal disease, which if left untreated, can be fatal within hours. Each year, of the 2.4 billion cases of diarrheal disease recorded worldwide, 1.3 to 4 million are associated with cholera, including 95,000. In order to fight this scourge, a team from the London School of Hygiene and Tropical Medicine was integrated into the field from the start of the project. The involvement of these researchers made it possible to organise the systematic documentation of the work and the collection of data at the Uvira Cholera Treatment Centre. By analysing the number of admissions at the CTC and the volumes of water distributed by the network between 2009 and 2014, the researchers found that over the 12 days following an interruption in the supply of drinking water, the number of patients admitted at the CTC increased by 155% on average. There are several reasons that can account for this sharp increase. Contamination of alternative water sources in the event of a service interruption, degradation of hygiene, which can promote disease transmission when water is scarce, or the contamination of the network due to insufficient pressure or the presence of biofilms protecting cholera bacteria. In short, the first result of this study is clear. It is necessary to ensure the continuity of the water supply in the areas affected by cholera. Regularity is one of the essential keys in the fight against this deadly disease. The second result requires taking a step back. That is to say, no longer seeing cholera as the only target, but to consider diarrheal diseases as a whole. Indeed, since the implementation of rapid detection tests in 2016, 60% of patients admitted did not have cholera, but other diarrheal diseases. In addition, molecular tests carried out on 269 patients showed that 45% of them were infected with several other pathogens. What does that mean concretely? The identification of circulating pathogens can guide prevention strategies to make them more effective. The details of these operational insights, drawn from 5 years of epidemiological research, are available in the policy brief published by Éditions Agence Française de Développement.
Yes, thank you, Florent. So that will be my final word. And just to stress the importance of continuity in access to drinking water, we experienced a stop in the in access to water in Uvira in 2020 because the infrastructures were damaged during a flood in spring, and research showed that cholera cases jumped following this event. So just to stress how water and continuous access to water is crucial in the fight against cholera. Thank you.
Great. Thanks a lot, Benedict, for this presentation and this nice work you're doing in South Kivu. I would like now to invite Alinta Gelling, our next speaker, who will discuss also the importance of drinkable water provision and their particular solution and tools that they have been able to develop in West Africa. Alinta, the floor is yours, and give me 1 minute just to put your presentation on.
Good afternoon, everyone. Thank you for this opportunity to present our work. My name is Alinta. I think we have a very nice flow in this presentation, in the order of all the presentations, because I work for Uduma, I work in Mali, and we are a rural water supplier. So we actually continuously work to provide access to drinking water. And in this presentation, I just want to show what we as a private actor, how we can play a role in in the spread of diseases, and also concretely our actions, something that we did during the COVID epidemic. So next slide, please. So just I will shortly just start with Uduma, because I'm not sure if everyone knows what we do. So we heard about towns and urban settings with outbreaks. So we work mostly on the other side. We work on the small installations in rural areas, and also this is often this is a very important. There's many people, over 50% of the sub-Saharan population lives in remote areas, and this is exactly where we are providing water. Yeah, do the next slide. So just so you have a bit of background, so Uduma is a subsidiary of Udial Solutions, which is the mother company of Vernier Hydro. It's a bit better known than Uduma. With Vernier Hydro, we have 40 years of experience, mostly in Africa, in over 45 countries. And so we work from the supply of infrastructure, so mostly pumps and all the equipment, to the management, which is Uduma's core activity, so the management of water supply. So as I said, we specialize exactly in those remote areas. Next slide. So instead of exactly explaining what our business model is, I will just tell you why we consider it a disruptive approach or a disruptive business model. So I won't go into the details. First of all, we address the entire chain of water delivery. So we start at the rehabilitation of water points. We work on the maintenance, but we also work on water quality, chlorine treatment, and in the end, also revenue collection. So our work is based on the simple but effective hypothesis that profit generates sustainability. So we do this by entering into long-term contracts with the local authorities. So these are, they grant Uduma the exclusive right to operate their pumping equipment. So and then we sign a concession contract with the commune or the public authority. And in this contract, we stipulate all the rights and obligations of all parties. So the customers or users of the water, as well as the public authority, as well as us. as the private actor. So it also includes esterification of the water. And to keep our expenses low, so just to make sure that we keep our operational costs as low as possible, because we work in remote areas in the end, we use as much as possible new technologies that are adapted to offline areas. And lastly, we have a really strong private sector approach. So we put private sector at the core of rural water supply. This is what we call disruptive, because water supply is mostly approached from a non-profit perspective. So let's go to Mali, where I work. Voila. So I work in Bougouni, which is in the south of Mali. At this point, we're managing around 250 water points, and we're adding to it every day. We have approximately, we target around 50 rural municipalities and approximately 500 villages. If we go a little way back now to the theme of this session, I looked up some data for Mali, and we see that still 28% of the rural population in Mali does not have access to at least basic drinking water services. And 91% of the population does not have access to basic hygiene. So the work we do, so there's still a lot of work to do in our sector in Mali. Next. Voila. So I wanted to, in general, to introduce a little bit what we do. So it's not just that we go into a village and we implement our strategy, or our, it's not as simple as that. So if a village accepts our management system, so all the contracts are signed and they agree, we go into the village with a collaborative approach. So it's not just that we put on the pump and now we start paying for it. It's also discussing with the village and talking about all the teams that are related to it. So we held discussion groups. We talk about the water quality. We talk about hygiene, what we do for treatments, and the importance of potable water. So, but then during the COVID, no, a bit too fast. During the COVID epidemic, we felt that we had a responsibility to go a bit further. It was not enough to, in general, talk about hygiene, but we wanted we started a pilot with hand washing stations, because what we wanted is our water points should not be hotspots of high risk of contamination, but more on the contrary, feel like a safe zone where we could disseminate messages, where we could disseminate good practices against COVID in this particular case. And these were zones where there was not really a lot of information, especially in Europe, and there was a lot of information about COVID, and it really affected everyone's lives. Whereas in the zones that we work with, it was not necessarily the case. So this is why we started this pilot with 20 hand washing stations, with soap distribution with it, and a radio campaign that would accompany it. So since we already have this whole infrastructure in place, we go to the villages. We have to be there regularly. We use this infrastructure to set up, and we used our people. So we work with caretakers at every water point, and they would be responsible for the soap distribution, make sure that the hand washing stations are always filled. So we used our basic infrastructure. Next slide. And this is, I think, what I think is really important. We had our infrastructure in place. We have really a last mile distribution, and then we had to distribute these hand washing stations. So there were a few things that we learned. For example, to keep it as simple as possible, I put this picture in because I really liked this hand washing station, which looks very nice. But imagine transporting this to a remote area in a limited amount of time. So this, even though it looks nice, it had to be practical as well, in terms of logistics, in terms of costs. We went to very simple, robust systems that were locally made, because we also learned that the more you involve the local community or the people in the whole implementation phase, the more also opportunity you had to distribute your message. So we did production locally. We also the soap distribution, for example, we asked the women. In most villages, there is a women's organization that makes soap, for example, and the soap would come from the community. And instead of going in the end, we decided that we would not distribute a hand washing station in the village, but we looked for a bigger town close to the villages, and then we invited everyone to come over. And this was a moment where we could also talk about COVID, talk about the importance of hygiene. So we would invite 2 people from every village, and they would get really specific information, which they would take to the village with their hand washing stations, and they were responsible to distribute the message further. Next slide. So this would be these kind of meetings, where this a picture of our distribution meeting. Voila. So then there have, I just wanted to add that during those meetings, we realized that there were many questions about COVID. So this actually what inspired to add the radio campaign to it, because we realized that very few people knew what was actually happening. Voila. So, and last slide is, as of today, we have, this pilot was very successful. They're all still in place. The caretakers continue to fill up the water. There's still soap at every hand washing station. And we can say that at least those villages use and understood the message that was spread. And therefore I want to stress that this last mile distribution networks like we have, but we're not the only one. There's Coca-Cola also has it, solar home systems have them. They can be very interesting existing networks in emergency distributions. So we talked about the blanket approach. I think we cover pretty much every village in certain areas. So these are networks that I would invite people to use more. We do have a role that we can actually play there. And if we look back, so we really look to adapt the tools to the target population. It sounds obvious, but it's not always the case. And we would also, what we really learned is to keep it as local as possible, as I explained. So to relate back to the theme, fighting water-related epidemics with long-term approaches, we as a private sector, we are there for the long term. So we have those systems in place, and we're not going anywhere because this is our source of living. This is where we work for. So not only is it at our core to have a continuous water supply, but we can also do a lot more. And I think we could be involved or used more than that we actually are at this point. We just did a start. We just had a limited amount of hand washing stations that we distributed, but I hope it can inspire further action.
Okay, thank you very much, Alinta. Thanks for this example from the private sector and your involvement in water distribution, hand washing station, and community integration also in the decision making. So we are reaching the end of our presentation. So we've seen a bit of research applied to emergency wash field. We've seen from the French Foundation involved in multi-year, multi-sectoral approach to fight cholera, and this quick presentation from Uduma on the water distribution. What I can say is to conclude quickly that we definitely need to have an integrated approach from government, private sector, public, to continue to to fight epidemics. Could it be cholera or COVID as it happened recently? And long-term programs also are something really important to eradicate diseases in most of the areas. And saying that, it's becoming in the SDGs, the Sustainable Development Goals that everybody is talking about those days, in which is something important, and there is big events arriving next year. And SDG 6 particularly, and 6.1, 6.2 related to water and sanitation. Those we know that are lacking in progress, and the last GMP report said we need to quadruple the efforts to reach the target by 2030. And as a reminder, there is over 2 billion people that drink water from contaminated sources, and 2.4 billion people that are without basic sanitation facilities. On these last words, we still have a few minutes that I would leave the floor to the attendees. If there are any questions, I think you can either write it in the chat box or switch on your mic by raising your hand. I think I have the hand on that. So don't hesitate if you have any question to our speakers.
I think there is one question in the chat box.
Okay.
From Anna about the main differences of CATI compared to regular responses and the number of persons in the household that must have a big impact on the numbers. I'm not sure I get the second part, but maybe just to respond on that. So the main difference is, I mean, it depends how you define a regular response, obviously, but the main difference would be that it's targeted compared to a blanket approach. I mean, some of the differences have been addressed during the presentation. But this would be the main one, and Bram can complete. And regarding the number of persons in the household, of course, it has some impact. The unit we target is the household and not the individual. But obviously, the sizing of the intervention is related to the size of the household, particularly, for example, in relation with the content of the cholera kit that we distribute. That can be affected by the number of people, but this is, I mean, quite a regular impact on normal the wash distribution intervention. Bram, if you want to complete.
I think you've covered it, Baptiste. It's about increasing number of aquatubs to make sure households are able to treat their water for long enough. It's about increasing the number of bar soaps. Basically, that's it. I mean, disinfection is not going to be affected. This happens in the most risky areas within the house. So toilet, kitchen, under the beds. I mean, where we know there's evidence of high risk of Vibrio cholera being present. And the other question you've answered as well. So yeah, it's about using the limited resources most effectively. So you do it in households where you know there is a suspected cholera case, instead of trying to cover an entire area.
Mm. And there were a comment from Arco. Yes, yeah, go ahead.
I have another point. When I was a student, more than 46 years ago, my uncle advised me, because he was WHO advisor, being a having a PhD in bacteriology. But he was advisor in Congo. So that is in the 1960s and 70s. And from that time, there was already this advice to use biscuits during the night, because then you can have an effective additional remedy against cholera, because then the stomach is empty. Now, that is just an old advice. I'm not a doctor myself, but perhaps there are even much better advices at the moment. But we are partner of Uduma in several interventions, and I must stress that your work is brilliant. I like it very much, because it is important to make a bridge between the emergency responses to diseases and the continuous effort to improve the hygiene situation of drinking water in rural areas. And the hand washing devices Aquafrol also has supported during the COVID outbreak proved to be very important. And to additional evidence, 2 days ago, there was bacteriological research done on manual pumps in Uganda. And even when a chlorine disperser was built in the manual pump, the effect inside the house was not visible. So people are not trained to wash their hands regularly and effectively. And even with chlorine in a manual pump, before it is pumped into a kind of jug or a jerry can, after a certain number of hours, the water is infected anyway. So hand washing is very important, and training, the awareness raising remains very important. Although, of course, I agree that if you have an emergency outbreak, chlorination of water is necessary. So that was my point. But thank you for your presentation.
Thank you, Arco. And I would like to thank also Julie, who put a comment in the chat through the CIWI platform. Thank you for this comment, and well noted. Guys, we almost reached our time, 6:20 sharp. Well done. I think we will not take any more questions. Thanks for all the participants who have been present. Thanks everybody for the quality of the speeches and the work you are doing. And have a good day, and see you soon.
Thank you, Florence. Thanks, everyone. Bye-bye.
And enjoy the World Water Week.
Thank you.